Hello and welcome to this session. I'm Elna Rudolph and I'm the president of the next Congress of WAS in South Africa in exactly a year from now. I'm co-hosting this series with Esiet from Nigeria, who's the honorary president of the Congress. I'd like you to please tell us where you are from. We've got 500 registrants on this from all over the world and some people joining us on Facebook Live. So please tell us in the chat where you are from. We are very proud to be presenting this fourth WAS conversation to you in association with our partner, the Human Reproduction. Oh, now I am stumbling over my words here. Our partner, the Human Reproductive Program. So, which is the UNDP, UNFPA, UNICEF, WHO, World Bank Special Program of Research, Development and Research Training in Human Reproduction. And our topic for today is the sexual health chapter in the ICD-11, implications for providers of mental health and sexual health care. This series is planned by the core team who is planning the Congress in South Africa next year. And it is Alan Jehami, which is our scientific chair, and also Eric Janssen, the vice chair, and it is the executive of WAS, and then Anthony Smith from South Africa, the president of SASHA, and also Marlene Wasserman, the local scientific chair. And there are some people popping up on the screen now. I'll ask the rest of our panel for today to also switch on their cameras so that I can introduce you to today's team. So we've got on the screen there Pedro Nobre, he's the president of WAS, and then we've got Esther Corona, she's the vice president of WAS from Mexico. And we've got our two moderators for today, Eli Coleman from the USA, and we have Leanne Gonzalez from Geneva. And then we also have our speakers, Lale Say, who's also in Geneva, and then Ruben Hernandez, who is in Venezuela. We've got Gail Knudsen from the USA and Kevin Wiley from the UK. So welcome to all of you. We are really looking forward to your contributions today. Thank you for your time and your participation. I'm going to hand it over to Pedro briefly to just say hello to you as the president of WAS.
Good morning, everyone, or good afternoon, or good evening, depending on where you are. Welcome, everyone. This is a very important session, WAS session number 4, dedicated to the sexual health chapter of ICD-11. And I just want to actually say that this is a very important development because, as most of you know, this is for the first time in history that there is a specific chapter on sexual health in a classification system. And WAS, the World Association for Sexual Health, played also a role on the development of this chapter. And I would like to say, and actually to thank to Lale Say and Leanne Gonzalez from WHO and Human Reproduction Program, of course, for partnering with WAS for this very important, organizing this very important session. This is very important also for us. And I want also to say special thank to Eli Coleman. Many of you know Eli is WAS past president, and he was actually the one who organized this very important session. And he played also a very important role representing WAS in the development of the ICD-11 chapter, and in particular the sexual health chapter. And just to conclude also, thank you to Ruben Hernandez and to Kevin Wiley, actually both WAS past presidents who are going to speak also on this session. And last but not least, a very important greeting to Gail Knudsen from WPATH, actually our very important partner and member of WAS actually also. And she was actually also WPATH past president. So thank you very much for making this possible, and I will hope everyone enjoys the session. Thank you.
Thank you very much, Pedro. It's so nice to see people here from Trinidad and Tobago, Botswana, some South Africans, California, the UK, literally all over the world. Thank you for saying hi. I'd like to ask you if you have questions for our panel, please put that into the Q&A. They will not be moderating the chat. They will look for your questions in the Q&A, but you're welcome to chat to us. Luis and I will be looking after that. Oh, I think I might have forgotten to introduce Luis when I was doing my introductions. He's the Secretary General of WAS and very, very helpful in organizing all of this. So I would like to just start with a poll. Please, Michelle, if you can put up the poll for us. Our first question is just that we want to know from you on a professional level what it is that you do for a living. There you go. So are you a psychiatrist, a general practitioner, a sexologist, whether you're a medical sexologist or a psychosexologist, a psychologist, an activist, a member of the general public, or you identify as other? We would just like to get an idea of who's joining us here today. And then I'm going to go over to introducing you to our moderators for today. So first up, we've got Dr. Eli Coleman, who is Professor and Director of the Program in Human Sexuality at the University of Minnesota Medical School. Professor Coleman is one of the founding editors of the International Journal for Transgenderism and is the founding and current editor of the International Journal of Sexual Health. He has published extensively on various topics related to sexual health. He is one of the past presidents of the Society for Scientific Study of Sexuality, the World Professional Association for Transgender Health, WPATH, you'll hear that acronym often today, the World Association for Sexual Health, and the International Academy for Sex Research and the Society for Sex Therapy and Research. He has probably ticked every single box there is to tick in sexual health. So he has been a frequent technical consultant on sexual health issues to the WHO and other organizations, and has been a recipient of too many awards to mention here today, but it's very impressive. So thank you, Eli, for your time and for putting this together. We really appreciate it. And then Leanne Gonzalez, I hear I pronounce your surname very different to Pedro, so please excuse my Afrikaans pronunciation of it. But Leanne is a technical officer with the WHO Department of Sexual and Reproductive Health and Research, where she has worked since 2013. She is the department's focal person for sexual health. In 2017, she led the development of WHO's operational framework for sexual health and its linkages to reproductive health. Ongoing research involves exploring linkages between sexual functioning and other health conditions, as well as identifying global data and guidance needs related to sexual health and associated practices and behaviors. She earned her MSPH at Johns Hopkins Bloomberg School of Public Health and her PhD at the University of Basel. So thank you, Leanne, for also joining us and making this possible. And for the two of you, I am really looking forward to seeing how you manage this panel. Over to you, Eli.
Okay, it's very nice to see everyone and see all people from all over the world. Can we have the poll results? I'm really interested in seeing who has joined us here. Look at all the sexologists, psychologists, psychiatrists. And it's really important that the psychiatrists and psychologists are here, because I think that this conversation has particular relevance to them as practitioners who, again, used ICD-10 and looked at these number of these diagnostic classifications from the perspective of mental disorders. And we're going to be talking about today the inclusion of this new chapter on sexual health. It's interesting that this chapter has evolved. In 2002, WHO revised its definition of sexual health. And years later, here we have a chapter that really looks at the many aspects of sexual health. And I think that this is really important for practitioners so that they can easily recognize the sexual and gender health conditions as part of their practice and realize that they are not simply mental disorders. The chapter destigmatizes many of these conditions. And in the case of gender incongruence and sexual dysfunctions, it really rescues them from the mental health section of the ICD-11. It also ends the oversimplification of the mind-body split. And it recognizes that one needs to take a biopsychosocial approach to assessment and treatment. As WAS is in official relations with the World Health Organization, I am the liaison officer from the World Association for Sexual Health. And it has been my utmost pleasure to work with Leanne Gonzalez, our focal point within WHO. We have been envisioning this session for some time, and we're very happy to bring this idea to fruition today. We have 4 outstanding panelists with us today. And Leanne, I just want to say thank you for all of your hard work on sexual health within WHO and working with all the partners on this issue. It gives me great pleasure to work so closely with you. And so now I'll turn it over to you. Thanks.
Thanks, Eli, and it's wonderful to see you over Zoom, even if you are so far away in person. Good morning, good afternoon, and good evening to everyone online. It's wonderful to see so many people from around the world participating today. As Eli said, my name is Leanne Gonzalez, and I work in WHO's Department of Sexual and Reproductive Health and Research. And I want to start off, just so no one falls asleep too early, with another poll question. So Michelle, if you wouldn't mind putting up a second poll question. So we're going to be talking about the ICD-11 today. And we wanted to start off by getting an idea at the beginning of the session. Right now, how comfortable or competent would you feel using ICD-11 codes, the new codes, in clinical practice? And you'll see the 3 topics that we're going to cover today: paraphilias, gender incongruence, and sexual dysfunction. And so you can be honest, let us know how you're feeling, not competent at all, fairly competent, or very competent. And while you're filling this out, I will say that the development of the International Classification of Diseases 11th revision, which includes this brand new sexual health chapter, is a process that took the better part of a decade to complete. So it is really exciting that we have it now approved as of May of last year, May 2019, at the World Health Assembly. The countries of the world who participated in the World Health Assembly approved the ICD-11, bringing us into a new era from development into transitioning towards implementation. So now from 2019 until when some of the first countries start to implement, we're going to see countries and medical practitioners around the world starting to transition from ICD-10 to ICD-11 and adopting and implementing these new codes. But it's the healthcare providers, many of you who are on the online today with us, who are going to be the ones who are going to need to use these codes in practice. And so for this reason, from our side, from WHO's side, this webinar is a unique opportunity to reach out both to the memberships of the World Association for Sexual Health, as well as the memberships of the World Psychiatric Association, and to really bring together providers who work in mental health, sexual health, and the intersection of the two to talk about this new chapter and to talk about what the implications are for the providers who will be interacting with this chapter the most. So the format of the session is going to be, as Eli had mentioned, we're going to start off with a broad overview of the ICD-11. We don't expect everyone in here to be an expert on it. It is quite dense, just to give you an idea of what it is and what it isn't. And then we'll drill down on the new sexual health chapter. So we'll take a closer look at 3 areas where we've seen a really substantial evolution in thinking: the acknowledgement of the mind-body intersection that Eli mentioned, or a lot of oh God, I can never get this word right, depathologizing of certain concepts. So we'll be focusing specifically on paraphilia, gender incongruence, and sexual dysfunction. Before I introduce our next speaker, our first speaker rather, I wanted to see, Michelle, if we have any results from that poll. Oh, brilliant. Okay, so we have a fair number of you who are feeling fairly competent or not competent at all. So I really hope by the end of this session today, you will have learned at least a few things that are useful for you in your practice and in your just operations as people who are interested in mental health, who work in mental health, interested in sexual health, or work in sexual health. Now, without further ado, I'm going to introduce our first speaker. It is my absolute pleasure to introduce my former boss, and dear colleague, Dr. Lale Sai. Lale works at the Department of Sexual and Reproductive Health and Research with me in WHO, and here she is unit head of the SRH Integrations in Health Systems team. Lale has worked at the World Health Organization since 2002, leading monitoring and evaluation activities and subsequently serving as the coordinator of research capacity and program strengthening, and later the coordinator of the Adolescents and At-Risk Populations team. Before joining WHO, Dr. Sai has worked at the Ministry of Health in Turkey in managing and implementing programs, and at the Istanbul Medical School with clinical, research, and teaching responsibilities. Dr. Sai has published substantially in various areas of sexual and reproductive health, and she has a Master's of Science in Reproductive Health Research from Edinburgh University and a medical degree from the University of Istanbul. Lale, over to you.
Thank you very much, Lian. Thank you very much, Eli, and also thank you very much to WOS for organizing this exciting discussion today. I'm also, thank you so much to everyone. I see we have in this Zoom discussion close to 200, and I know also in the live stream people listening to us from all over the world. It's very exciting to be able to interact with you in this panel discussion today. I'll start my presentation. The next slide, please. By giving a broad overview of what is, and I know, and we saw from the poll responses that you are quite familiar with ICD and you have been using it. But again, it may be helpful we start from a broad description of what is ICD, how it has been used, and why WHO has been really working meticulously to make sure that it is current, it is factual, it is accurate, and it's usable. So as we all know, ICD is the International Classification of Disease and Related Health Conditions, is the international standard for actually reporting health conditions and diseases. So it's used for vital registration purposes, to detect and track evolving health and disease patterns, for individual patient records or facility surveys, very important and very wide use in insurance reimbursement, and also as a reference for treatment guidelines, scientific literature, and research. Next slide, please. And as I said, in addition to the ICD codes for these purposes there are ICD codes used for these purposes on diagnosis, on injuries, on encounters to health facilities, external causes, and also signs, symptoms, and findings, clinical findings. But there is also a larger use of ICD codes that goes far beyond these aspects of diagnosis or diagnostic aspects or outcome aspects. So it's used, for example, for histopathology, for classifying devices, for assessing the functioning, and for trading. We also have a new traditional medicine conditions, a chapter about, and many more of these purposes. Next slide, please. So Lian had mentioned the decade of almost 10 years of work on updating ICD-10 or moving from ICD-10 to ICD-11 really was very important to really make sure that all these use cases of ICD can be also used more effectively and more easily and more efficiently. And also it was important to make an update from ICD-10 to 11 to ensure that we are actually true to the most recent evidence in all health conditions, and we are also using the latest technology available. So one reason for the update to 11, ICD-11 was to improve usability. And when we were doing this update, we really were very keen about to ease the training needs of ICD-10 and to make it more efficient to be trained. And also to include more clinical details. As you know, ICD-10 didn't have definitions, or you could use only one single codes, but now in the new ICD-11, there is a possibility to use multiple codes for one condition. Other reasons for update or other maybe results of the update included improved indexing, improved incorporation in electronic environments with different interfaces, software interfaces, updated scientific content, as I said, according to the latest evidence and facts that have been published in the scientific literature over the years, linkages to relevant other classifications, and improved comparability of adaptations. Next slide, please. One of the biggest changes or improvements in ICD revision towards ICD-11 has also been said is the new chapter on sexual health in the ICD-11. And again, I will not repeat, but it was mentioned in the introduction why we needed this chapter. And it's also based on the WHO's working definition of sexual health. And also the revision process that really lasted for some years, compiling all the evidence, consulting with all relevant stakeholders and parties, especially people who are using these codes, identified the need for more robust identification of sexual health beyond reproduction. So there was a need to revise codes where an understanding of the conditions has evolved over the years, and the disease didn't fit with the initial chapter or the parent chapter in ICD-10. In doing this revision, and some of you I know have been part of or have been engaged or have been consulted, we really had a different consultation mechanisms. There were a number of expert groups, working groups, expert groups, both in sexual health, reproductive health, mental health expert groups. They all have discussed different background documents on the evolving science, as well as listening to the users' perspectives, and also the communities, the affected communities' perspectives. So following that, we had a number of processes that really shared the drafts with the community and with the international users to get final inputs. Next slide, please. We also published in the scientific journal, peer-reviewed journals, to really get also input from that context. Very, very briefly, so in the sexual health chapter, we have the following measurable or reportable concepts: sexual dysfunctions, sexual pain disorders, considerations in sexual dysfunctions and sexual pain disorders, and gender incongruence. We also have other conditions that are in the sexual health chapter frame, but have primary parents elsewhere. So one of them is FGM, female genital mutilation, or changes in female genital anatomy, sexually transmitted infections, paraphilic disorders, and contraception management. The ones that are blue in my slide are the topics that we will discuss more in this panel, but I'll just very briefly touch upon the changes or the issues about gender incongruence and FGM. Next slide, please. We'll start with FGM. Very briefly, again, there was a lot of discussion as to how what this chapter should include, and female genital mutilation was one of the topics that really the groups or the expert groups and also the following consultations really thought needs to be is very relevant to this chapter. which is the partial or total removal of external female genitalia and other injury to the female genital organs. As many of you know, there are 4 categories of FGM, can have lifelong health implications, and also having it in this chapter will really help improve the quality of data, and which is key to eliminating FGM, which is an important goal for WHO and global community. Next slide, please. In relation to gender incongruence, again, we all know in the ICD-10, we had 2 different groups, transsexualism and gender identity disorder of childhood. These are reconceptualized as gender incongruence of adolescent and adulthood and gender incongruence of childhood. And they were moved out the mental and behavioral disorder chapter. So this was a big change. For many years, it was under the mental health chapter, and the reason for that, really, Eli very eloquently put that, really to separate that, to avoid separating body-mind issues, and really it deserves something more comprehensive, coherent, and something more complete in this new chapter. And it is moved out of the mental and behavioral disorders. And the reason that it was still kept in ICD is really to make sure that the health needs for these conditions are supported, to reduce stigmatization, to affirm human rights related to these conditions, and to ensure the depathologization of the diagnosis. Next, please. So currently, the current status related to ICD-11 is, you probably know, in May 2019, ICD-11 is adopted by the World Health Assembly and officially became the new tool for ICD. So now we are in the phase 1 between 2019 and 2021. This is, some member states really want to adopt it as early as possible. So they are really preparing how to implement ICD-11, and then with that experience and the work that is being conducted in 3 years, there is continuous feedback to continue to refine codes and content. And the plan is to really start implementation in January 2020. Again, some countries are very keen to start implementing in 2022. So that's the, and then until 2020, there will be accompanying tools that will be translated in all relevant languages. Next, please. Just my final few slides about how, if you are interested to get involved, to look for more information, or to ask questions, or if you have comments. Next slide, please. So you can use ICD-11 from the browser, and then you can explore the codes. You can look at the categorization according to the codes. You can look at the primary parenting and secondary parenting issues in all the chapters, including the chapter called Conditions Related to Sexual Health, chapter 17. Next slide, please. And also you can be involved by on going to the maintenance form by providing your feedback and comments. Next slide, please. And finally, currently where we are, as I said, anyone can go and provide comments, or a group can go and provide comments. So we have been receiving comments in relation to the sexual health chapter as well. And we are continuously reviewing the comments that are received. Some of them we can respond, or we can make a decision as secretariat, building on our previous work, and then we can send responses to the people who are commenting. Some of them, if we cannot decide ourselves, it may require a little bit broader discussion of the expert discussion or independent discussion. We can convene experts as necessary, when necessary. In these current comments, incorporating comments or conversations continue around intersex related conditions. So we are really working with experts or communities or users around the world to really see what are the issues, remaining issues around these conditions and how best we can come up with the consensus. And we are really hoping and trying to document experiences in implementing the revised codes across the world. So that was briefly my description about the new sexual health chapter in ICD-11, and happy to respond any questions if needed, but we really look forward to receiving more, your comments, your experiences, and you can always reach us from ICD browser comments section or to Lian and me from this, following this conversation. Thank you so much.
Thank you, Lali. That was great. That was a wonderful overview of the chapter and putting this chapter in context with the whole revision of ICD-11 and encouraging people to make comments. And so that was really very helpful. And as a great introduction to our three panelists who will go into the three areas that we're talking about. Can we have the results of the poll and just see how people feel about their knowledge of the various conditions that we're going to be talking about? There we go. So of the three topics discussed today, how competent do you feel you're using these codes? So you see there's lots of learning still to do with the paraphilias and for gender incongruence and for sexual dysfunctions. It's nice to see that some people are really familiar already, but hopefully this session will deepen your knowledge about this. So without further ado, I'd like to introduce Ruben Hernandez, who's going to talk about the paraphilia section. And I'm very pleased to introduce Ruben. He's one of the prominent pioneers in sexology and sexual medicine who has been advancing sexual health all of his career. He works in the forensic psychiatry department in the Central University of Venezuela. He is one of the past presidents of WAS, who I had the honor and privilege of working as his Secretary General during his term of office. He is the past president of the Latin American Federation of Sexuality Societies and Sex Education, founder and past president of the Venezuelan Society of Sexual Medicine, founder and first president of the International Academy of Sexual Medicine, the founder and honorary chairman of the section on psychiatry and sexual medicine in the World Psychiatric Association, and scientific director of the Sexual Health Education Program of the WPA. He was president of the 9th World Congress of Sexology in 1989 and president of the 5th International Congress on the Treatment of Sexual Offenders in 1998. Ruben, very glad to see you. Welcome, and looking forward to your talk.
Okay, good morning or good afternoon or good evening. Thank you for inviting me to participate in this very important session on ICD-11. I will concentrate my talk on paraphilias, who has been a very important topic to discuss in the medical and scientific area, because this all started in the 19th century. Please, next slide. So if we do a quick review of the changes of the concept and the areas of the paraphilias, we should start with Kraft Ebing in 1895, when he presented the work on Psychopathías Sexuales. That was a landmark study, perhaps the beginning of sexology as a scientific area, and we must honor his work. Then John Money in the Love Maps presented 40 types of paraphilias, in the World Congress in Jerusalem. It was in 1981. And this created a lot of discussion at that Congress. Then we have Brenda Love, who is from San Francisco. She presented a book and a thesis called Unusual Sexual Practices that was presented in the World Congress of Sexology in Rio de Janeiro in 1993. 400 kinds of behavior are in her book. Then Eli Coleman presented an excellent paper in 1992 about compulsive sexual behavior. After that, Robert Francoeur presented in the Sexual Dictionary in 1995 about 900 kinds of sexual activities that could be described as paraphilias. Of course, that a classification like the ICD-11 can take 900 codes in just an area of the sexology field. Then we have the World Congress on Violence in 1998 in Caracas, Venezuela, when we discussed it in depth, the field of paraphilias, and there was an extraordinary debate between the Czech Republic and Germany, talking about the importance or the right to do castration, chemical castration or chirurgical castrations in people who are committed serial crimes in this area. Chiara Simonelli in Rome organized a Congress on perversiones sexuales, was the main theme of the Congress that she organizes in Rome. Then Alan Jamy, who is here, presented a very good paper in 2015 about the relationships between the DSM-5 and the ICD-11. Rome organized a... Sorry? Okay, sorry, there was a feedback in the sound. And then recently, Geoffrey Reed and his group presented a paper on disorders or related to sexuality, ICD-11 in 2016, sorry. And Richard Kruger and his group presented the proposals for paraphilic disorders in 2017. So we have now the ICD-11, who was presented in the 18th of June in 2018, and who will be implemented worldwide in the whole countries in the 1st of January on 2022. Please, next slide. So the definition of paraphilic disorders is very difficult area. And the group that presented the ICD-11 reached a consensus. And it's a long definition that you can look at the webpage of the WHO, because they did excellent work in the Global Clinical Practices Network, and also in the guidelines for the implementation of the ICD-11. Mainly, the definition says that this is a persistent and intense patterns of atypical sexual arousal. So that's the main phrase of definition. Who included sexual thoughts, fantasies, urges, or behaviors that are focused in others whose age or status renders them or are unable to consent. And this is a very controversial issue. What is the age of consent? Because in most countries, the age of consent varies between 16 or 18 years old. But this classification spoke at the limit as 13 years old as the limit for a conduct that can be a crime in the most of the penal codes. So the being able to consent is a big area of discussion, and we will follow this in the near future. There is an important point that this has to be marked distress in the person or in the patient, in the victim of this kind of behaviors. And finally, the significant risk of injury, of death, especially in some kinds of behavior like asphyxiophilia, for instance, who are even presented in several films. So I urge you to go to the Global Clinical Practices Network of the WHO when you will review this definition carefully, and then we will start to describe the 7 codes that are included in the classification. So the first one is the exhibitionistic disorder, who all of you know that is the exposing one's genitals to an unsuspecting person in public places. This area has been discussed because what is normal or what is abnormal will be discussed for many times. In some countries and in some cultures, to be in a nude beach, for instance, is a complete normal consensual activity. But some people, especially in taking into account the religious factors, consider this kind of practices abnormal. Of course, that if you do this in a consensual way, nobody can tell that you are a paraphilic. The second one is also controversial because the voyeuristic disorder can be observing an unsuspecting person who is naked, disrobing, or in sexual activity. So if you are doing this activity in a consensual way in your room, in your area, some persons use that for increase your excitement in the sexual activity. So the voyeuristic disorder must be something that is done without the consenting factors in the person. The pedophilic disorder is now on the table because there is a big discussion nowadays, especially in some countries. In Holland, for instance, there is a political party who has a platform defending the pedophilic disorders. But we have a duty to our children, and we have to do very careful about the duty of care for our children. So the pedophilia is involving prepubertal children less than 13 years old. The issue of the age of consent, as I told you, between 13 and 16 years old is a matter of still big discussions. And recently, we have the Epstein case in the US, or the Roman Polanski in France now, who are typical cases of persons involving in sexual activity with minors. This is a very, very controversial area because somebody is trying to depathologize the pedophilia that, to the best of my knowledge, will be a big mistake if we don't protect our children or if we don't take care of the persons who are involved in this situation. We have to differentiate paraphilias from paraphilic disorders. If you do something that can be put you in prison for some long time, depending of the culture of each country. Next slide, please. Then we have the coercive sexual sadism disorder. And this also is a very controversial area because there is a physical or psychological suffering on a non-consenting person. So the classification clarify and exclude consensual sadism and masochism. And about 3 years ago, most of the countries in the world were awarded with the film The 50 Shades of Grey, who tried to use sadomasochism as a way to increase again your excitement and your desire for sexual activities. This will be also a very controversial area for some people. Then we go to the frotteuristic disorder, who is touching or rubbing against a non-consenting person in public places. And this is perhaps the most frequent paraphilic disorder. It's very common in the metro, in the bus, in the public transportation systems, the person who try to use this as a way to excitement. Then the other paraphilic disorders involving non-consenting individuals. And these try to use corpses, animals, and a long list of things that are a way to excite some people. And if you do without consenting, then you can be specified as a person who has a paraphilic disorder. And finally, the paraphilic disorders involving solitary behavior or consenting individuals. There are so many boundaries about all these 7 described paraphilic behaviors and paraphilic disorders. So I urge you to see the guidelines in the ICD-11, because then you will see in the webpage on the WHO a long list of relationship between another psychiatric disorders and other problems that arise that can be discussed, and where is the limit? Where is the line between normal behavior or a paraphilic behavior? The main consensus of the classification is the issue of consent. Next slide, please. So there are very controversial issues in this classification, and it will be. If we do research in this area, we will find a lot of many new things, because this is an area that nobody talks openly about it. It's a dark side of psychiatry or psychology, and we have to understand the differences between a normal consensual activity or a really paraphilic disorder who is doing harm to another people. So the age of consent will be a discussion for so long time. We don't have a clear discussion about what is happening between 13 and 16 years old. So we have a lot to do research in this area, because it is very frequently right now. There are so many films and so many video series that speculate with this point. Then we have a big discussion with the DSM-5 and the ICD-11. It was in Vienna 3 years ago in a congress that was supposed to try to reach a consensus between the two classifications. But unfortunately, we couldn't find a consensus between the two classifications. So we must encourage, because this is a world audience, to speak about the ICD-11 and to try to promote this classification as a way to communicate between scientists and medical or psychological professionals in this area. So the classification must be a reliable, must be a valid, and it will have a clinical utility for many purposes, especially this area, because as I told you, nobody talks about it. So it will be very important to describe these codes and to follow the discussion for the near future, and perhaps we will change some of the things that I am talking about. If we take in account the insurance and reimbursement issues, this is a very complicated problem, because we must defend the medical and psychological view of these issues and not to depend on the insurance companies who will say how many sessions do you have for treatment of any kind of sexual behaviors. Then we have the issue of depathologization, who is a very common discussion in so many parts of the world now in the area specifically on pedophilia. And we have to differentiate all of this from erotical sexual activity for pleasure. Pleasure is so important. It was launched a declaration in the past World Congress in Mexico City, and this declaration of pleasure is a landmark together with the Declaration of Sexual Rights of the persons who are looking for care and for treatment in this area. We need an urgent need for research in public health to try to do a very good scientific work in the field of the paraphilias and in the field of many other areas of sexuality. And finally, the treatment of paraphilias is also very controversial, especially with consensus or non-consensus in the prison settings and so on. Nowadays, we use cognitive behavioral therapy, we use antidepressive medication, specifically SSRIs, we use antiandrogens, medroxyprogesterone acetate, and we use gonadotrophin release hormones. Next slide, please. Here are 4 references for the study of anyone who is interested in this area. The ICD-11 guidelines, there is the webpage, Global Clinical Practices Network, the paper of Alain Jamy between ICD-11 and the DSM-5, who talks in depth the problem of the sexual norms. This was published in Archives of Sexual Behavior. Then the 2 papers mainly used for the development of this classification, the Geoffrey Reed Disorders Related to Sexuality and Gender, published in the World Psychiatry, because this session will be recorded and you will have time to look at these references and to look after this. And finally, the Richard Kruger and his group, who were the main classifical areas for the development of the classification. So in summary, The new classifications delete fetishism and delete fetishism transvestism. We change the exhibitionism to exhibitionistic disorder. We specifically talk about voyeuristic disorder, pedophilic disorders, coercive sexual sadism disorder. Fraud-heuristic disorders remain the same. And then we change the multiple disorders of sexual preference, delete that, and use the paraphilic disorders of sexual preference involving non-consenting individuals. The last one is to eliminate disorders of sexual preference unspecified and to change it for paraphilic disorder involving solitary behavior or consenting individuals. These are the main areas of discussion for the near future, and we are hoping that all of you can be in South Africa next year, when I am sure that this topic will be discussion in perhaps a workshop on trying to include all the areas of discussion of this very important area for sexology and psychiatry. Thank you so much.
Thank you so much, Ruben. I appreciate that. And that was a very thoughtful and systematic summary of what I know has been a lot of work and a lot of work over a subject that can be quite difficult even within this space. And I thought that you spent a lot of time just really making it clear that what we're really trying to remove in this transition from ICD-10 to 11 is, consensual sexual behavior between individuals is fine, and that we really wanted to capture more of the non-consenting aspect of this. We are going to fly so that we can try to stay back on time. So thank you again, Ruben. I'm going to ask Gail Knudsen to please open up your camera, open up your webcam. It is my pleasure to introduce Dr. Gail Knudsen, who is a clinical professor at the University of British Columbia's Faculty of Medicine and a consultant psychiatrist at Vancouver Coastal Health. Dr. Knudsen was a co-author of the World Professional Association for Transgender Health, which many of you know as WPATH, their Standards of Care version 7, and she's a co-lead of the Education and Ethics chapters of the upcoming Standards of Care version 8. She previously co-led the WPATH ICD-11 Consensus Committee. Dr. Knudsen currently serves as immediate past president of WPATH and co-chair of WPATH's Global Education Initiative. She has also held leadership positions within the American Society for Reproductive Medicine and the International Society for the Study of Women's Sexual Health, or ISWISH. Gail, over to you.
Thank you, Leanne, and thank you for inviting me to this panel this morning. I'm talking to you from Victoria, BC, and the sun is almost up here. And so hello to everyone good afternoon and good evening. This morning I'd like to talk to you a little bit about paradigm shifts in transgender health. And I think it's really important when we start talking about this topic in that in Ruben's excellent talk prior to this, he was talking about how diagnoses shifted over and what diagnosis they kept and what diagnosis they deleted. It's very different in terms of transgender health, that whole concept, and there's been a big paradigm shift with respect to transgender health. I noticed when we did the first poll that but there was a mixture in terms of people that had little knowledge versus medium knowledge versus expert knowledge with respect to transgender health. And in terms of a definition or WHO definition, transgender is an umbrella term that describes a diverse group of people whose internal sense of gender is different than that which they are assigned at birth. And so that's the definition that I will be using today. I'd also like to bring greetings on behalf of our President, Dr. Vin Tangpricha, and the WPATH Board of Directors. Next slide, please. I have no disclosures. Next slide, please. In terms of learning objectives, I'd like to talk about the paradigm shift and also provide a very brief overview of the new classifications. Next slide. This slide illustrates the paradigm shift in transgender health from the 80s moving forward. And the main type of work that has gone on in this area has been looking at in terms of gender identity. So in prior versions of both the ICD and also the DSM, if a person's gender identity was different than the sex assigned at birth, the person's identity was seen as pathological. The work that has been done over many groups, by many groups of people, clinicians, activists, community members, is that the thinking and the belief is that person's gender identity is not pathological and gender diversity is not pathological. So as Dr. Lally was saying earlier, it's the movement of the diagnoses related to gender have come out of the mental health chapter to decrease stigma towards this population and populations. Next slide, please. So when we're looking at the ICD, which was ICD-10, which was published in 1990, we can see that there is a huge shift when we look at ICD-11. So two things or three things have happened, is that all of the diagnoses related to gender have been taken out of the mental disorders chapter. And in terms of what codes are there, are actually now in the sexual or the conditions related to sexual health chapter. Next slide, please. So looking at the codes that were there in terms of the F64 codes, the gender identity disorders, all of these codes have been removed. And I think what's really important is that we're not moving them from one place to another. They have been removed completely because of the reconceptualization of how we think about gender incongruence. Next slide, please. In terms of what codes are present in ICD-11, it's gender incongruence of adolescence or childhood, gender incongruence, adolescence or adulthood, gender incongruence of childhood, and gender incongruence unspecified. So gender incongruence is defined as a marked and persistent incongruence between an individual's experienced gender and the assigned sex, or sex assigned at birth. Can you go back one slide, please? So when we're looking at this, I think there is another really important concept in that when people had a gender identity that was different than the sex assigned at birth, that it was that the gender identity had to be opposite. And it was a very binary, it was a very binary type of model. Identity is now seen as a spectrum. And so you can notice in terms of gender incongruence that it's a difference between an individual's experienced gender and assigned sex. So there's no binary component in there. Next, please. So looking at the classification systems, we looked at how the classifications have changed with respect to gender identity. And it's not about the person's gender identity, but the stigma that is associated with the person's gender identity that is placed on by society. We see that in DSM-5, gender dysphoria, this was in terms of the DSM-5 diagnoses, that this was the dysphoria that the person was experiencing with respect to their gender versus the assigned sex at birth. However, now looking at gender incongruence, there does not have to be a dysphoria component with respect to gender incongruence. But there is a coding in there in terms of gender incongruence, and hopefully now in terms of DSM-6 that we will be able to lobby to have gender dysphoria removed from subsequent versions of the DSM. Next slide, please. So in terms of these challenges, what challenges do you anticipate with respect to the diagnosis with respect to gender incongruence in your practice as it relates to transgender health? And can you start to bring up the polling, please? So as we look at the polling, this was one of the challenges that was put forward in terms of the healthcare system not recognizing these codes outside of mental health. And I would be interested in my colleagues' opinions on this as we go into the question period. Kevin is a past president of WASP, but also a past board member of WPATH, and Eli is a past president of WPATH as well. Second, I see that people are not, this is not coming up as much of a problem, like being unable to see patients or clients in my clinic as they will be out of scope of the clinic. 11% of people do not agree with the changes, and they think that it is a mental disorder. So I think that that's where our work comes in terms of educating people in terms of that gender incongruence is not a mental disorder, and much more education needs to be put in this area. And 56% that, and I'm so happy that this number is what it is, in terms of the gender incongruence of childhood should not be included in ICD-11. And then this has been a matter of great debate and continues to be. And I think that as time goes on, that this number will probably increase from 56% when we were doing our consensus group studies around the inclusion of gender incongruence of childhood. The numbers came up as 50-50. Also, when we did a poll in the membership, is 50-50. But I think these numbers are moving, and that they're moving higher. And also, in terms of the last bullet point, in terms of that it will take a decade or more before my region to adopt this this manual. And again, in terms of the health systems, I think that this may be a problem, and that it takes many years for the systems to adopt the new ICD. Thank you. Next question, please. So I just briefly like to tell you about WPATH. We are founded in 1979, and we currently have over 2,300 professional members and student members. This is our website that you can see many things about the different programs that we're doing and our upcoming conference. And next slide, please. And so one of the things that we are known for in terms of WPATH is our standards of care. And we had based our standards of care based on the terms of gender dysphoria, and that actually came out before DSM-5. And so now, in terms of our standards of care version 8, and Eli is the chair of standards of care version 8, it will be coming out in 2021. And in terms of code, if there are any codes that are going to be discussed, it will be gender incongruent. So I'd like to thank you. And the next slide, please. I'd like to invite you to our Global Education Initiative training sessions. And we are doing those online as well, and to our symposium, which will be held in November 6th to 10th. And we invite you to register online at wpath.org. So thank you so much.
So I'm going to be introducing Kevin Wiley right now. Kevin is a past president of the World Association for Sexual Health, and he was the first doctor in the UK National Health Service to be appointed as consultant in sexual medicine. He worked full-time in andrology, sexual medicine, sexual therapy, and gender medicine for the NHS across 2 hospital trusts in Sheffield until his retirement in 2017. During his time in Sheffield, Kevin became honorary professor of sexual medicine at the University of Sheffield, and was a visiting professor at Sheffield Hallam University. He's held various professional positions at the University of Sydney, Yerevan, and Liverpool. He's published over 100 original peer-reviewed publications, and many on sexual dysfunctions. So he has also been the past president of the European Federation of Sexology, and has been very active with WAS as president and as past president. And I'd like to turn it over to Kevin now to talk about the sexual dysfunctions. Thanks, Kevin.
Eli, just before you turn it over to Kevin, I wanted to encourage just to stay mindful of time. I'll encourage panelists to take a look at the Q&A, and if there are questions that you can answer by typing, please do. We've had quite a lot of active flurry there. And of course, if we have any time at the end, we will absolutely try to do some in person, but for now, typing. Over to you, Kevin.
Thanks very much. It's an absolute pleasure to be a member of this panel, which is showing this revolutionary paradigm shift of the international classification system. Many of us have contributed into it and tried to implement this in our clinical and teaching programs over the many years, and I hope that this will now become part of your typical practice. I'm going to just briefly show you the first few slides so that we can move on to some of the areas of difference. So the next slide, please. In these 12 minutes, we're looking at the first couple of topics have really been covered fairly well by the previous speaker. So I'll spend most of the time outlining the major changes, the significance of these changes, and the implications for clinical practice. So the next slide, please. The ICD-11, all of you can find it at this URL. It's a new chapter on sexual health, and it does bring together several conditions that were historically classified elsewhere. There's substantive advances in research and major changes in social attitudes, policies, laws, and human rights standards, which have made this possible. And as you've already heard, gender incongruence, but also sexual dysfunctions, sexual pain disorders, and many of the older paraphilic disorders are no longer classified as mental health conditions. Next slide, please. So many organizations have been involved, and it's been great that WHO has worked so closely with them, with WAS steering the way. Next slide, please. So the chapter 17 lists the conditions relating to sexual health, and if we concentrate on the sexual dysfunctions, you'll see that they are hypoactive sexual desire dysfunction, sexual arousal dysfunctions, orgasmic dysfunctions, and ejaculatory dysfunctions. Next slide, please. The important thing here is that the diagnostic categories apply to women and men wherever relevant, although there are some separate categories existing where there are obvious sex differences that require that to be the case. There are also notable differences from the DSM-5, and this was an area particularly with women's sexual health, where there was discussion about the sexual interest and arousal disorder being placed together in the DSM-5, which the general consensus was against in ICD. And also the problem or difficulty, if it's defined, should occur frequently, although it may be absent on some occasions. It should have been present for at least several months, and it should be associated with clinically significant distress. Next slide, please. So just to give you examples, this is how you define these. So the hypoactive sexual desire dysfunction in women or men may be lifelong or acquired, it may be generalized or situational, or it may be unspecified. And you can find all of these definitions on the ICD website. For those of you who have been making questions about this, you need to go to the link that I shared a few moments ago. And then if you click on the little triangle, and then click on the dysfunction, you get the definition thereafter. Next slide, please. For the sexual arousal dysfunctions, this is split between female sexual arousal dysfunction, male erectile dysfunction, and other disorders. Next slide, please. The third group are orgasmic dysfunction with anorgasmia, again, in either women or men. And there are always the space for other specified or unspecified dysfunctions. And the next slide, please. And this is ejaculatory dysfunctions, which of course are listed mainly for male. And we've got early, delayed, or retrograde ejaculation. Next slide, please. Then the next section, which can't really be dissociated from sexual dysfunctions, are the pain disorders. And you can see here that the removal of some terminology and change to sexual pain penetration disorder. And the good thing about the electronic ICD-11 is that the other conditions that may be considered appear in grey on the classification system. So you can look for dyspareunia, which is in the previous chapter on genitourinary problems under non-inflammatory disorders of female genital tract. Next slide, please. Now, the important thing here, and this is really very important for understanding the coding system, is that the etiological considerations can be marked alongside any of the disorders that we've already talked about so far. So They are, as they're listed on the screen, so just typically they could be medical conditions, psychological problems, psychoactive substances, medications, lack of knowledge, relationship, cultural, and other concurrent sexual problems or sexual pain problems. Now this slide here, which I've taken from a publication that's about to be available in Sexual Medicine Reviews, is co-authored by Sharon Parrish and Sarah Kotler-Casanova from the US and from Switzerland, respectively. They're joint authors with Anita Clayton, Rita McCabe, Eli Coleman, and Jeffrey Reed. And I think this is a really helpful table that shows the transition on the right from the ICD-10 into the new classification system on the left, which is the ICD-11. And you can see here the new terminologies and how it best maps. And this applies for both the sexual dysfunction and the sexual pain disorders. It also shows which areas have been removed. And so all of this information can be found on the electronic ICD-11 on either chapter 16 or 17. Next slide, please. So I want to suggest a clinical case of a 57-year-old woman presenting to gynecology and with an 8-month history of pain during sex. The clerking doctor identified no pathology on examination and was unable to replicate any of the pain. But she did notice that the woman was withdrawn and reticent to discuss matters further. So using the ICD-10, the doctor diagnosed vaginismus and depression and arranged for the woman to return to see the consultant at the next clinic. At the next appointment, the consultant was absent, but the clerking doctor identifies that the woman also reports a lack of interest in sex. Now, it's assumed that this is secondary to the pain during intercourse, and so no further questions are asked. Indeed, the lady is prescribed an SSRI, an antidepressant, because she appears depressed. The woman then goes back to the reception and asks for another appointment, but to see another healthcare professional. Next slide, please. Now, 1 year earlier, we find out that the woman had heard from her friend that her husband of 23 years had been having an affair with a joint friend. The woman had gone on to confide to her friend that she'd gone off sex since suffering the pain during intercourse from the time of the menopause. She was avoiding sex and she thought it must be her fault that he was seeing somebody else. Her friend helpfully suggested that she contact her GP. When she saw her GP, she was told that this was a very common situation, but that the specific problem with the vaginal pain was treated with topical estrogens. Now, 8 months earlier, the discomfort had improved, but knowing of the affair, she told her husband that the pain was still there. And this was the problem that, of course, she was presenting to the gynecologist with. One night after having had a couple of drinks, she broached the subject of the affair with her husband. Unfortunately, he was both verbally and physically abusive towards her and blamed her for all the problems. So now when she saw the consultant in the clinic, the woman declared that actually she was still interested in having a sexual relationship, but not with her husband at the current time, if ever again. She started to fantasize about what sex would be like with the man that she sees in the gym that she visits regularly. Next slide, please. So using the new classification code, you can see that the principal diagnostic code here may be HA00.3, which is hypoactive sexual desire dysfunction, which is acquired and situational. So it's not there all of the time. It's associated with HA40.0, a medical condition, and you can find these within the search categories within the ICD online, and you find GA30.2, postmenopausal atrophic vaginitis. Now that has improved, but it may relapse if the treatment's not continued. It's also associated with HA40.1, psychological or behavioral factors, including, of course, mental disorders, although the depression in this case may not be of that significance for a formal diagnosis, but is certainly having an impact on her well-being. HA40.2, the use of medication, and this could, of course, be an adverse effect of the SSRI that the junior doctor had provided in the clinic. HA40.4, relationship factors are clearly a factor here, and so interpersonal distress is very important. relationship distress with spouse or partner can be coded at QE51. And lastly, HA 40.Y, other specified etiological considerations in sexual dysfunctions and sexual pain disorders. And it's important here that we can co-code with HA 20.3, sexual pain penetration disorder, acquired and situational. Next slide, please. So there are 5 significant points of the ICD-11 which we can think about, and one of the most important is the riddance of most of the pejorative terminology that remains within the clinical discussion to date. Terms like impotence and premature abound in urology clinics, and frigidity to a lesser degree in gynecology. But there is one term that I did make point of, and I know that Ishwish made point of, which remains, which is superficial pain. I don't think anybody who has vaginal pain or vulval pain would say that it was superficial in any way. And so introital is still a possibility there. There's a unified classification system which has evolved from the previous separation between either organic or non-organic or psychological dysfunctions. And so it's now much more possible to have an integrative clinical approach, which is how many clinicians are now working in teams. It allows for linkage with associated and/or concurrent conditions. And so the HA40 subcoding, etiological considerations, is very helpful. The traditional association that all sexual problems were a consequence of mental illness has been removed. And so there's a reduction of stigmatization by removing this from mental disorders. And it allows more people to seek assistance from healthcare professionals without fear of having a mental disorder listed on their medical record. And there's the potential risk of medicalizing sexual dysfunctions, which is best addressed by working in a multidisciplinary way. So hopefully that's not going to happen. The last slide looks at the 5 of the implications of ICD-11. And the first of these is that it encourages identification and appropriate treatment strategies formulated by both mental health and non-mental health specialists. The majority of people, for example, with erectile dysfunction, will have either cause or effect of psychological contribution or cognitive factors for their condition. Whether or not this is contributory or inhibitory to the action of prescribed treatments from PDE5 inhibitors can only really be best addressed by having more than one person or overview of a problem and its management. The dimensional approach is really helpful because it allows inclusive consideration and management of comorbidities of any dysfunction, rather than you having to exclude them or them being seen as potentially contributing and having to be treated first. So it allows us to treat patients concurrently for comorbidities. Importantly, it legitimizes the formal training programs of sexual medicine for physicians and healthcare professionals. Too few medical schools provide this. Even at Sheffield, when I was teaching, we had a day and a half out of 5 years of teaching to talk to our students about sexuality and gender, and is failing to reach very far into many postgraduate training programs. So hopefully now this will move it out of this, because it's no longer just a mental disorder. Indeed, it's a sexual health issue. It also extends validity to the knowledge of and research of the breadth of sexual function, behavior, and expression. Too often, the taboo about sex has been paramount and thrived in medical circles. Now that the internet and social awareness is much better about sexuality, colleagues who end up working and helping people with sexual health will no longer be viewed with caution that they perhaps were in the past. And finally, it respects human rights within sexuality, sexual health and well-being. And this ties very closely with the WAS Declaration of Sexual Rights, which we reissued in 2014, particularly around point 7 for a pleasurable, safe sexual experience, and point 9 for the right of information. And no time's tied, so I'm going to hand straight back over to our moderators.
I will actually interject here, and
I don't know
why there's such a bad echo on my voice, but okay, there it sounds better. But I would like to thank all of the panelists and the moderators, and I would like to thank all of you for attending. And I would like to invite you to stay on. We'll ask one question for each moderator, but I'll formally close the session just so that you feel okay to go if you want to. And I would like to invite you to our next session, which will be on gender-based violence on the 7th of October. It will be a panel of world-class speakers just like this session, and we'd love for you to register. And then, of course, I'd love to invite you to come to South Africa next year for the World Congress. Our president just announced last night that our borders are opening on the 1st of October. So we hope that everything will be fine for you to come to South Africa in September next year. We are, of course, also looking into options to bringing it to you wherever you are in the world. So thanks again for joining. Thanks again for our distinguished panel and moderators. And there's a video about South Africa that entices you to come, that will play right at the end. But for now, I would like to pass it back to Eli to just maybe ask one question to each panelist. Thank you.
I'd like to ask Lali a question. Lali, given the controversies over the child and adolescent gender incongruence that was discussed by Gail and that has come up in the questions, is there any mechanism for that is being planned for review of that diagnostic classification?
Thank you, Eli. Thank you. I didn't respond to individual questions, but I see here also some questions came. And again, as you know, we have been receiving a number of comments or questions from individuals or organizations. So we are reviewing them. It seems that we will have to look at some more in depth to all these feedback and questions. And our intention or our, we envisage we may set up a small working group that will look at all these, inputs across the globe and then see what is best. Because as I said in my presentation, this is an ongoing process. And the beauty of ICD-11 is really, it allows us making modifications to the codes or to language across the board. So I think we are able to see, we may not make everyone happy. So that's another thing that happens not only on this topic, but with many health topics. WHO is receiving so many different views, but our job is to really synthesize them and to have a consensus that's, that is acceptable to the majority. So stay tuned. We will be continuing to review literature, review feedback, and then have some expert expert, but also user, but also community discussions in the near future. Thanks so much.
Thank you, Lali. Leanne?
There we go. I saw there were a couple of questions that came up from a person named Mehmet who was asking Kevin about the distinction about clinically significant personal distress versus interpersonal distress. Because I know we mentioned, and we see this across the ICD, we also saw this in the paraphilias, that one of the things is it has to be causing marked distress, and the assumption is that it's personal. So I wasn't sure whether either Ruben or Kevin had a thought on whether that can be personal versus interpersonal, what that interplay was and what those conversations look like around that determination.
Certainly for these sexual dysfunctions, it's clear that it says the problem or difficulty must be associated with clinically significant distress. It doesn't say that that has to be only for the individual, but of course the problem we've had in the past is that partners have said that it's causing them distress and the individual isn't having a problem with the condition. So perhaps this is something that needs to be clarified, or in the coding needs to be clearer, whether it's both causing personal distress. Of course it can be causing interpersonal distress because we can code for that with the relationship and couples issues. But with regards if only the partner's distress, then of course that would be inappropriate and something that has quite rightly been removed now from the opportunity from somebody sort of sending their partner to the doctor or the clinician with a problem.
Thank you, Ruben. I don't know if you wanted to add anything to that.
Thank you, Ruben. I don't know if you wanted to add anything to that.
Oh, Ruben, you're muted.
A long way and has consulted about more than 5,000 people who is working in the field. So it's very difficult to reach a consensus. The consensus was to name market distress in the person. So this will be a matter for discussion in the next few months.
Thank you so much. Eli?
I think we're good. I think we ought to turn it back over to Elna to wrap it up and talk about South Africa and on to the next Congress.
Thank you very much. Michelle, will you please play that video for us now?
Dear you, waiting to explore our beautiful city will be worth it. Until then, we will maintain our long-distance relationship with you. We are waiting for you to experience our natural beauty and our friendliest locals. And to share our greatest adventures with you. Distance means so little when a city means so much. And when the time is right, we will still be right here because we are worth waiting for. Love, Cape Town.
If you haven't been to Cape Town, 2021 is your year. So please follow us on Facebook, on Instagram, and attend our next webinar on the 7th of October on gender-based violence, and we will continue to give you more information as it becomes available. Thanks again for joining us, and thanks to the panel. Goodbye.